Awesome. Thank you guys for, oops. Do you see the correct screen here?
I see. Let's see.
The lecture?
I do not see the lecture.
Hmm.
It says screen broadcast.
Weird. I see that. Did that improve anything?
Yes, it did.
Okay, great. All right, thank you guys and gals for showing up for case reviews this month. There was a little delay in getting things started, so I appreciate your guys' patience. This month's case reviews are, I think, a little bit different in the sense that they're not as, they're more educational regarding some uh, situations, I guess, instead of being overly dramatic and grand kind of cases. So going forward, as always, this information is confidential and privileged. We should be protecting that information under the HIPAA Act, and that we shouldn't be distributing, copying, or sharing this outside of this educational purpose. And then whoever is unmuted, unless it's Prentice, please mute yourself. All right, so moving forward to case one. This is a case of a 69-year-old woman. And Steve, are you available to discuss?
Absolutely.
Awesome. So I wrote up the initial assessment for you based off of what was documented. So feel free to read through that. And it's just as a reminder, Steve, then we move into treatment, which is documented in the narrative, the times and the treatment. So just so you have an idea of the reminder of the flow.
Yeah. So we responded priority two to an adult foster home for an unconscious fainting subject. We got there, staff brought us into a room. Patient is in bed, dressed, covered up with blankets, wearing a hat, and not really responding. Lights on, but nobody home, eyes open, but not tracking. Staff says she has a history of a stroke. She cannot use her left side. She typically gets up in the morning, tries to walk, goes down to the ground. They come in, they find her, they pick her up, they put her back in bed. That's a daily routine. This morning, they find her on the floor, they pick her up, put her back in bed. But now she is less responsive than her baseline, which is typically a little bit confused, but conversant. We come in, start talking to her. She doesn't really respond to us. She is ice cold to the touch. My partner says, I cannot get a blood pressure on her. I said, well, let's go ahead and palpate one. He says, I cannot get a radial. Okay, well, let's put her on the monitor and see if we can auscultate a blood pressure. While we're doing this, staff comes up and they tell us about this resident of theirs. They said she was placed there about 3 years ago. Her son and daughter do not come to visit. Son has never visited. He is the power of attorney. Daughter has visited once. They're both down south of Salem. So as we're talking to them, they give us a DNR post form that is checked, do not resuscitate, comfort measures only. We start talking to staff about this post form, and we highlight the section that says patient does not wish transport. Well, they get very upset. They say family doesn't care. We care. She's family to us. Please, you need to do something. Well, we talk it over. We kind of go through what the whole idea of comfort measures is. They said, anything you can do, please. Can you take her to the hospital and make her better? we tell them, we will tell you what, we'll kick this up the chain. We will do what we can. We will take her to the hospital. We load her up, put her in the ambulance. We're able to get a EKG on her limbs, but we still cannot get a blood pressure. Staff said when they picked her up in the morning, they had a blood pressure in the
54 over 30.
50 over 30 range. So we kind of explained she may be going into the hospital, but I don't think she is going to survive this. They said, well, we'll get you her list of medications. So before we leave, they come out and they hand us a packet. Got it. We take off. We're headed to Southwest. We do our Pulsara and let them know we have a patient who's actively dying. DNR comfort measures are with us. Well, as I go through the packet, there is a second pulsed form that is newer than the first. This one has comfort measures marked and scribbled out and then selective marked with somebody's initials next to it. And at the bottom, where the physician signs and the son power of attorney signs, they sign them in the wrong spot and they draw a little arrow pointing that, oh, this should be in the other place. So I don't know if this is a valid DNR or pulse form. So I elect to keep her, just we give her warmth, we give her a little blow-by oxygen, and basically hold her hand as we come into the hospital. We're assigned a room toward the back, one of the larger rooms, and I give report to the nurse, and I say, this is where the plot thickens. We have two, we might say, conflicting pulse forms. She's not real sure what to do, so she calls for physician, and I leave it in their hands at that point.
Thank you. I think that was a really good explanation of what you were dealing with. Is there anybody have any questions or clarification? So go ahead.
Could I just jump in? And it looks, I see in the notes here, it looks like, contacted the power of attorney, but that just went to voicemail. So it sounds like tried to get some clarification from the power of attorney.
Yeah, we tried calling while we
correct?
were still on scene. Yeah, we tried calling while we were on scene, and they said, yeah, they never answer us.
Yeah, and then a couple other things that was documented in the narrative is that you guys asked the patient if she wanted to be transported. Is that correct? And that she had stated yes, so that was kind of more confirmatory that she's not refusing. We have conflicting information. Is that correct too?
Yeah, they kind of did the shaken baby thing. They shook her hard enough that she, cried out, and they said, "Do you want to go to the hospital?" Yes. And that was pretty much the only verbal we ever got from her.
Okay. And then the only other thing is and I only mention it here because it'll be part of kind of the discussion in the QA discussion, is that in the narrative, you just like what you described, that you get a second packet of paperwork that now has a different advance directive that is conflicting with the first one, but in our documentation, it was documented that that form was received and then transport was initiated, as opposed to figuring this out close to arrival to the hospital. Thanks again for presenting that information and being available. I really appreciate it. Moving into the discussion for this is that I really thought that despite the fact that you guys were given this DNR comfort only patient, you got an early set of vital signs. As you can see, it was within the first few minutes of patient contact, 2 minutes, and that you did recheck vital signs instead of just checking in one time. You reviewed the initial paperwork, attempt to contact the POA, and deferred to transport since unable to confirm what the goals of care were. given the conflict between the staff and the reported documentation from the POA, as well as what the patient had kind of under duress elected to. I think that when we do transport these patients, even if they are comfort only, that we should get an exam, and that I wrote in here no intervention, no intervention. I think that if the thought process was that the second advance directive was actually not active or wasn't valid, then potentially the no interventions would make sense. I think that letting the hospital know beforehand that you have some conflicting information that could drastically change their response would be helpful before arrival if that information is available beforehand. And that was why this case had came up, is that the nurse taking care of this patient had brought it up as concern that they were behind the 8 ball when she arrived. I think that especially since this information came to light after transport was initiated, and speaking with you like shortly before arrival to the hospital, documenting in the narrative that you got this information, then transport started, and you looking back at transport being, approximately 17 minutes, you're kind of thinking there's enough time to at least notify the hospital that there's a conflict. So make sure that your documentation doesn't kind of put you in a bind with saying that transport was initiated after the second form. So that's all that I had in regards to reviewing that. And I think that given the limited ability to confirm the POA's wishes, especially since you have two different forms, I think that it makes sense about, your I don't want to say confusion, but more of you're not sure where to go with this and trying to elect to at least transport the patient and kind of work this out with more hands and more resources. Anybody else have anything to say before moving towards the patient course?
No, I agree. It's a really difficult situation, and that if there's that question, then generally the safer option is to transfer to the hospital to let where you have more time and resources to sort it out.
Mm-hmm.
The only other option you have is involving medical control.
Yeah, absolutely. That's another potential as well. And I can tell you that given both, if this was an online medical control call, and knowing most of my partners with having a DNR Comfort and a DNR Limited, they would probably say, even if you don't believe that the DNR Limited is valid, why don't you just bring them in and we'll figure it out. So in the emergency,
Dr. Gebler,
yeah.
Oh, I was just going to say, I struggle with follow-up Pulsara forms, but talking to the charge nurses, they're more than happy to take a phone call, run it by them, or one of the physicians. So that's something that I certainly could have done.
No, I appreciate that insight as well, and that self-reflection. I don't know if I guess I can't say that, updating through Pulsara or updating through the radio is better or worse, because, it really is just dependent on how busy we are in the emergency room and who's physically available to look at the Pulsara or to look at, or answer the radio. I can tell you that the Pulsara tones are always going off, it seems like. So it may not, I don't know. I guess make sure that make sure the hospital's updated, and, ideally they respond back and acknowledge that they received that update. So in the emergency room, the patient's initial vital signs were quite abnormal. Heart rate of 50 as reported with the pre-hospital assessment. Blood pressure was 40/28, respiratory rate of 15, and the temp was 89.6. They reviewed her pulse form and decided that the DNR selective would be valid. They contacted her sister, who okayed labs, IV fluids, antibiotics, and imaging kind of in line with DNR selective. Her initial lactate was 11. Her pH was pretty low or pretty acidotic at 6.96, and her hemoglobin was pretty low as well, down to 5. They noticed there was some bruising on her left leg, and they got an x-ray noting that there was a tibia fracture there, so that moved them forward with imaging all parts of her body. So she had a CT of her spine, her head, her chest, abdomen, pelvis, and that was really the only abnormality was the tibia fracture. They gave her, I think it was 3 liters of IV fluids, which did improve her blood pressure, but never normalized it. They contacted her sister again, who said she'd be okay with initiating vasopressors, getting her a blood transfusion, and placing a central line so that she can get the vasopressors, and that she would be okay with her going to the ICU. I will say, in reviewing this case for case reviews, I wasn't necessarily aware that DNR limited meant that they usually don't go to the ICU. So that was kind of a little knowledge to me that this patient, although DNR selective, also got an ICU admission. So all in all, in the emergency room, she received 3 liters of IV fluids. She was externally warmed with a bear hugger. They treated her empirically with antibiotics due to concern for possible sepsis, and she got pressors in the form of Levophed. She got blood products and a central line. Her hospital course, that despite her pressors, she became more hypotensive. Her kidneys failed. She developed hyperkalemia, and her bicarb continued to decrease. In that she was getting to the point where they were having difficulty with oxygenating her, which might have been related to her mental status or her hypotension with an unreliable pulse ox, but ultimately her sister decided to make her comfort measures, and she passed away the following day. So initially I was just going to talk about the pulse, but recently I participated in a session that I think that maybe a little bit talk about the advanced directives and the terms and when it's valid might be helpful for a reminder for everybody. So what is an advanced directive? It's what health care preferences a patient might have for what they want for themselves in the future. How is it performed? It's not always done just by documentation. It can be done by talking, it can be done by sharing their wishes to others. And this comes from the Washington Advanced Directive website. So presumably this is the most accurate, up-to-date version of it. Who do you discuss your wishes with when in regards to your wishes for advanced directives? The term is a healthcare agent, although you can also you can also use the words legal decision maker, surrogate, attorney in fact, which I would imagine is like your POA. And then who can complete it? This is a little bit conflicting to what I found in the Pulse, but it says that you have to be 18 years or older to be able to complete advanced directives. And then what 2 types are there in regards to advanced directives? As in you have a durable power of attorney and a healthcare directive. And when does the healthcare agent or your legal decision maker or your surrogate or your attorney in fact weigh in about your advanced directives? When you cannot do that yourself anymore. So we had a discussion where POA, what is a POA? What are they a POA over, and like over what type of care for, or what type of instance for a patient? And when a patient is awake, alert, and oriented, can that patient have requests that can be honored, or should the healthcare agent or the POA be able to supersede the patient's wishes if they have the ability to make their own decisions? And that is inaccurate. They cannot, unless the patient cannot make decisions for themselves anymore. So that led me into, or this case originally led me into discussion of the PULSE form, the portable orders for life-sustaining treatment. What is required for it to be valid? The name of the patient, the date of birth, the date that this is signed, the legal decision maker's signature, the signature and date from a medical provider, and that both the patient signature and the medical provider's signature can be verbally recorded. It doesn't have to be the actual, according to the PULST form that was updated in 2021 on the state of Washington's website. So, we oftentimes report that a patient's advanced directives are DNR full treatment, DNR limited, DNR comfort, and that DNR part is just the first section of the pulse form in the event that the patient needs resuscitation. But if the patient has a pulse, then we move into section B. So that's why this piece is showing up here. In the very end of this presentation, I'll have an example of a pulse form to kind of reiterate that too. But once we go into full, limited, and comfort, we're down into level of medical interventions, and that's when the patient has a pulse and or is breathing. So full treatment is primary goal, prolonging life by all medically effective means. That means intubation is appropriate, advanced airway interventions are appropriate, mechanical ventilations and cardioversion are appropriate, and transfer to the hospital is indicated, including ICU. Selective treatment is that the primary goal of treating medical conditions while avoiding invasive measures when possible. You can use medical treatment, you can use fluids, you can use monitoring, but you don't intubate these patients, and you do the least invasive airway maneuvers. So that would be like CPAP, BiPAP, high flow. I know that it doesn't say particularly in here that an SGA would be appropriate. I have seen that used for the patient, but I think ultimately once we contact the POA and review the selective treatment goals, that they're like, we don't want to move forward with intubation, and we end up pulling the SGA and moving them towards comfort. I don't know if anyone else wants to weigh in on if an SGA falls into the selective treatment.
SGA is actually invasive. We consider it, and we did at the committee that rewrote the thing. We considered it a real intubation, an intubation. It's not a endotracheal intubation, but it's much more invasive, and it's what we would use in a full arrest to start with. So I would avoid that for our group.
Perfect. That's exactly, because like I said, I've seen patients come in with SGAs, and it's clearly not indicated in the allowable acts for non-invasive airway maneuvers.
Mm-hmm.
And then lastly is the comfort focused treatment. So primary goal of maximizing comfort, relieving pain and suffering with medications by any route that's possible, using oxygen, suctioning, manual treatment of airway obstruction as needed for comfort. And individuals prefer no hospital transfer. EMS can consider contacting medical control, determine a transport is indicated to provide adequate comfort. So it doesn't necessarily mean that they don't get transported, that there might be an indication for transport if it's a matter of aligning with their comfort. So for our protocols, I think that the most relevant protocol we have would be the DNR orders. At least when I searched their protocols, I think that this was the only thing that came up in regards to advanced directives in DNR. So DNR order, so it's a little bit not exactly like, your limited or your comfort only, but we'll just go over it. So DNR order is an order issued by a physician, although it can be issued by a nurse practitioner and a PA, that the event the patient suffers a cardiopulmonary arrest, cardiopulmonary resuscitation will not be administered. DNR orders are valid when a patient is under the care of a skilled nursing personnel. Patients in hospice and cardiac arrest is considered DNR without withhold resuscitation. A living will is legally executed. A living will is a legally executed document expressing the patient's wish for future health care, which includes patient preference for resuscitation. The POLST form is a legal document signed by patient and physician indicating patient preference for life-sustaining treatment. It's also signed by the legal healthcare decision maker, if I remember correctly, for the term. And it includes preferences for resuscitation. Resuscitation includes attempts to restore failed cardiac or ventilatory function by procedures such as endotracheal intubation, mechanical ventilation, chest compressions, defib, and ACLS meds. Our guidelines for DNR is that when the patient, family, friends, or nursing home personnel state that the patient is not to be resuscitated, BLS protocol will be followed while attempting to confirm their wishes. In the absence of the above, DNR order, living will, or POLST form, medical control should be contacted. The POLST form, DNR order, or living will must be documented in the patient care report. No BLS or ALS procedures should be performed on a patient who is a subject of a confirmed POLST, DNR, or living will, and who is pulseless and non-breathing. Go ahead.
Yeah, there is a little confusion about things that and we might have to think about this. A couple things just to mention. You mentioned about that someone be under the age of 18 can't have a they basically can't sign or do their own living will or their own POLST form. You can have a POLST form or a living will for a person who's under 18, but that has to be signed by their guardian, parent, whatever, because they don't have the legal means to or recognition. They don't have the legal recognition to be able to make that kind of decision. Now, a POLST form is the portable orders is the way that the EMS personnel can legally cease or not initiate resuscitation. And it's legal because it's a medical order, either from, like you said, a physician, a PA, or a nurse practitioner. Without that, there is no legal way for because EMS are not independent practitioners. They cannot. They're required to start. They cannot make that decision to stop. Now they can make if the legal order is from a physician is in the form of a standing order. That's fine. But that's what the POLST form is, and so there's quite a bit of difference between occasionally we get to a house where the patient has a living will, but that's not a POLST form, and a living will doesn't substitute for a POLST form legally as far as the physician or medical personnel to the EMS order to cease or to not start resuscitation. So in that case, it's much preferable if they only have a living will that you contact medical control. And medical control at that time could be either medical control or in the future a direct contact to your MPDs. Is that, did I explain that clearly enough? There was, when we rewrote the POLST form, we were in 2021, it was we brought it back to being EMS friendly because it was not EMS friendly. I just, for further information, we're also, one of the problems, of course, is always trying to find the POLST form or have the family find the POLST form. And we're trying to solve that at the legislature to get them to fund, just like they do in Oregon, a POLST registry so that you can make a phone call from the field with the patient's name and ID and within 1 minute, find out whether they have a valid pulse form or not.
One other thing I'd add is that, so when I was looking up advanced directives from the state of Washington, you had to be 18 years or of age or older. But when I looked up the pulsed form, it said that you can have a pulsed form if you have like a chronic illness. So it didn't
Right.
really have the age cutoff like the advanced directive. So it seemed a little bit conflicting. But the other thing too about the pulsed form is that it's still valid even if it's a copy. So if you, and I can put the link, actually the link is in the end in the references, but there's a pretty 21 page Adobe Acrobat Reader document on the state of Washington regarding the pulse form. And they state that it can be a copy, it can be a fax, all of those would be valid as long as it has these
Right.
parts completed.
I tell families and patients to take a picture and put it on your phone,
Yeah.
and then you always have it available.
Yeah, so it doesn't have to be an original copy if you're searching out an original copy.
That was one of the things we changed.
Mhm.
And the under 18 can have a pulse form, but it has to be, it's going to be signed by their caregiver generally, which is usually a parent.
Yeah. And then also in the advanced directives for the state of Washington, if you don't declare somebody as your healthcare agent, then it also goes through a list of like 10 to 15 individuals that would be given the opportunity to make decisions for you, but only 2 of the 15 don't have an asterisk, and the asterisk means that everybody that falls under that category has to be in agreement, otherwise they do full treatment. So it's a good thing to remind yourselves about for yourselves and your loved ones, and also for the patients we take care of.
Right.
Yeah, so if I could, and I agree with what's been said, just to summarize, like if you have a pulse, you can act on that. You don't have a pulse and there's a question, involve medical control.
Thanks. That was definitely a good reminder summary. All right, so moving on to case 2, it's of a 0-day-old or a newborn. And again, thank you, Prentice, for presenting that previous case. I don't have anybody else from pre-hospital presenting the rest of the cases. So initial assessment is that this child was in respiratory distress when the first in crews evaluated him, if I remember correctly, it was a him. I think it was a him. Anyways, he was unresponsive. His airway was open, but he was labored. There was accessory muscle use noted. He was pink, warm, and dry, but there were no signs of active bleeding. And the first set of vital signs were recorded 9 minutes after patient contact. His heart rate was documented as 158. No blood pressure, and respiratory rate was 44, SATs of 98%, and that's with supplemental oxygen. Since he was brand new, he had no past medical history or meds reported. In that the history provided to EMS was that he was a full-term baby that was delivered by midwives at home less than an hour ago or something short of 60 minutes. I don't know if it was just a couple minutes prior or not. They report that the delivery was normal and that there was respiratory distress following the delivery. The midwives stated that there was some meconium and they suctioned it after delivery, and that attempts were made for 60 seconds to stimulate breathing before positive pressure ventilation in the form of BVM was initiated. So vital signs reported to EMS prior to their arrival: heart rate of 158, respiratory rate of 44, SATs of 98%, GCS of 6. They arrived to find the patient being bagged at 4 liters a minute by the midwife, and they initiated their ALS assessment. Only 9 minutes after arrival, they initiated transport, and they recorded vital signs throughout the next 33 minutes of transport, indicating that the heart rate and the respiratory rate and the SpO2 stayed pretty much the same, which For this age of a child, I'll double check with my resources, but my recollection is these are all normal for a newborn. And I don't know if any of you guys have ever been present with me with a pediatric. I use my tools, my resources all the time because we can be fooled in thinking that we know normal ranges and they can be quite nuanced. So I use my vital signs in my tools all the time. So this is for a newborn, 100 to 205 beats per minute is considered normal, and respiratory rate from 30 to 53 is considered normal in a minute. So these are all normal for age. There's no Pulsera as this patient went to Legacy Salmon Creek, and at that time we weren't using Pulsera. And so the discussion in regards to what was done, I think, really well was there was early and serial vital signs performed on this child. A physical exam was documented. Documentation, including perfusion, was provided, and early initiation of transport instead of spending, prolonged protracted time on scene. Documentation of the delivery of the placenta was in the narrative, in that they also documented in their narrative that they initiated warming of the patient. One point that was brought up from the MPD's office is that it's okay to allow the midwife to ventilate the child, but need to document that it's effective. And because I didn't quite mention that in the previous slide, the midwife wanted to go to the hospital with the patient and continue to ventilate the child. So areas for improvement. One of the things that I had when reviewing this case is that there was a lot of documentation about the kind of atypical presentation, including, they documented the placenta and mom, her position, stuff like that. But I think somewhere in the lines of that the cord was clamped would be good to have in our documentation. And then entitled to be monitoring this patient if time allows, a blood glucose check. And then if we're concerned about respiratory and ongoing respiratory issues, an airway adjunct may be considered. What was documented in this narrative was that the midwife had stated when she didn't provide positive pressure ventilation and supplemental oxygen that the kid's SATs would drop down into the 80s. But it's not documented in the narrative because I believe that the child was ventilated throughout the encounter. So no hypoxia was recorded. Dr. Mock, is there anything that you'd add for the QA discussion? And most of this is some of your feedback already.
No, this is a really challenging case, and I think the question of how to use the midwife to the benefit of the patient, I think that comes down to some scene management and figuring out, like, okay, your job as the paramedic is to coordinate the best care for this patient. Do you have someone who can be helpful to you and who can further the patient's care? If that's the case, then absolutely make use of that.
Those are good points, for sure.
But if not, or it's interfering with patient care or something like that, we completely support you doing what you need to do to advocate for the patient.
So in the emergency room, the midwife had reported to the hospital that the 1 minute APGAR was 3, the 5 minute APGAR was 5, and the 10 minute APGAR was 7. Remembering 10 is the most numbers you can achieve on the APGAR. She also reported that there were decelerations prior to delivery, and the child was assessed by neonatologists, noted to be lethargic. Initial pH showed that the child was quite acidotic at 6.91. There was low CO2, or low bicarb, and then high CO2 of 61 on their gas, in that the patient was admitted to the NICU at Legacy Salmon Creek. So during the hospital course, the child was started on therapeutic hypothermia, found to have moderate hypoxemic, low oxygen encephalopathy. and ultimately was transferred to the NICU at Randall's. Unfortunately, we were unable to get the follow-up for this child, so I don't know.
I can
ultimately
provide
what-
follow-up.
Oh, great, perfect.
So the kid ultimately did have some intracranial hemorrhages, probably as a result of the of birth trauma, and there's some hypoxic injury, but overall the child's doing well. Followed up with the PCP. The last PCP visit was about 4 weeks ago and was doing well at that point. Following up with neurosurgery. But they don't anticipate intervention. So it seems like some developmental delay, but overall a kid who's hitting the major milestones.
Awesome. So I thought I'd talk a little bit about newborn resuscitation in the event that you were, like, we are on the scene by ourselves without anybody's assistance. So newborn resuscitation, as a reminder, is more focused on respirations than anything else than cardiac or medication related. So making sure that your patient's breathing adequately and has the correct anatomy for ventilation. So correct position of the head and shoulders. One of the things that I wanted to remind us about is that first breath is really, really important to help with the pathophysiological changes of the patient, the pediatric patient's circulation during pregnancy, and then after birth. So when the patient first breathes, and we're talking about the neonate, that it allows for the amniotic fluid to be absorbed in the lungs, and it allows for the pulmonary arterioles to dilate and the umbilical vessels to constrict. In that, as the pulmonary arterial pressures decrease, then the blood starts flowing to the lungs. So it's really important to get the child to breathe early on to help with the change in circulation that occurs after delivery. Pediatric resuscitations are different than toddler let me rephrase that. Neonatal resuscitations are different than ped/toddler/adult resuscitations in the event, or in addition to the fact that respirations are very much the focus of resuscitation, but also the only medication that would be reached for besides the rare chance of grabbing dextrose would be epinephrine, and really epinephrine only after aggressive airway maneuvers have been initiated. Other things to think about in regards to resuscitating a newborn, besides having the proper equipment and anticipating the issues that might occur, is to have a warm environment for the child, not only the environment that you bring the child into, if that's possible, but also prevent any further heat loss. So warm blanket, hat, stuff like that. In reviewing the newborn resuscitation information, they talk about the golden minute. The golden minute is that if the newborn doesn't start to breathe adequately after 1 minute, the odds are pretty high that the infant or the newborn is going to have some significant medical issues that need to be addressed. So recognizing if you're not getting your patient to breathe adequately or resolve cyanosis, that we're really potentially dealing with a high probability of dealing with an ill child. And then APGARs are requested to be done at 1, 5, and 10 minutes. So appearance, pulse, grimace, activity, respirations, with a score up to 2 for each one of those. And then blood glucose can be checked, and it should only be treated if it's under 40. And then we would be using a very dilute dextrose concentration. One of the things that I was reading about newborn resuscitations, I looked at our protocol and it didn't necessarily state that in our protocol, is that if we were moving, so when we go to this neonatal American Heart Association algorithm from 2020, so I believe this is the most recent one. But so in preparation trying to get that out of the way. I don't think I will. There you go. In preparation of the child being born, talking about counseling and briefing the team as well as getting a necessary equipment. If the child's born, this is all in the first minute. Is it a term child? Is there good tone? Is there breathing or crying? If we say yes, infant is having good tone and breathing, infant stays with mother for routine care, warm and maintain normal temperature, position airway, clear secretions if needed, ongoing evaluation. But if the child doesn't have good tone or good breathing, they're going to warm and maintain normal temperature without the being on the mother, position airway, clear secretions, and stimulate as necessary. If the child is apneic or gasping or their heart rate's below 100, then they get positive pressure ventilation, monitoring your SpO2, consider EKG monitoring. But if the child's breathing is adequate and the heart rate is, oh, I'm sorry, I missed. So apnea or gasping, heart rate below 100, then they go to no labored breathing or persistent cyanosis. And if that is present, then you're going to similarly position and clear airway, SpO2, monitor supplemental oxygen, and consider positive pressure ventilation. After a minute, if the heart rate, the next question that we have is the heart rate below 100? If the heart rate's below 100, you're checking for chest movement, ventilation adjustments, and potentially endotracheal tube or laryngeal mask if needed. And if the heart rate's below 60, then you're going to be considering intubation if you haven't already done so, chest compressions, and then coordinated with positive pressure ventilation, 100% SpO2, and transport. If the heart rate's still below 60, despite this, then you would be initiating IV epinephrine and consider hypovolemia and pneumothorax. So the only other thing that I was going to ask, especially since it sounds like we have Dr. Whitwer and Dr. Macht here, is that we really, if we're going towards intubation, I would be suggesting that we don't need to grab RSI meds in this neonate, as it's probably unlikely that it's going to be beneficial or necessary and could actually be detrimental. Would you guys agree about that they should not be?
Totally agree. I've intubated many neonates that, and you don't have teeth, you don't have an active gag reflex, and no, and that kid is already obtunded, so they're going to be very floppy, very easy to do. I would not complicate matters by, and if you would use succinyl choline, all you're going to do is Brady the kid down more. So the other thing is, when you're considering, I noticed that, and you correctly had, in that you correctly had using CPAP, but early on, but one has to be very careful because in your last bullet point, I have seen spontaneous pneumothorax that becomes then a tension pneumothorax in babies with very difficult intubations. And so if they continue to have trouble ventilating, if they continue to have bradycardia, one needs to think about a pneumothorax. And a pneumothorax is treated in a baby is the same way as you do an adult. You needle the chest. Mm-hmm. The chest is very shallow at that point, so you don't have to, and you do it in the second intercostal space, mid-clavicular, which is hard to find in a baby sometimes. So things to consider if you're not responding, and of course, if you're giving positive pressure breathing, just remember, a baby's chest is so mobile that you can easily see if one side of the chest is not moving.
Yeah. Now, this is our protocol. For the most part, I feel like it doesn't have any kind of question in regard to what I presented earlier. The only thing was that, we talk about if we need to intubate, and I think that just like Dr. Whitwer had mentioned, that trying to dose succinylcholine or
Nope.
etomidate, and the issue with medication dosing errors, and the chances are unlikely that it's even necessary. As a reminder that if you're at the point where you're going to need to intubate this child, that it'd be reasonable to try without getting any RSI meds.
Dr. Gabbo, the one
Yeah.
thing we did find on our when we reviewed this just recently is that somehow the bradycardic rate morphed from 60 to 80. So we are correcting that, and I think
This
that's
one right
all
here?
correct. Yes.
Yeah.
So the rate should be 60 when you start compressions.
Yeah, that's a good point.
Or
I
epinephrine.
meant to mention that. Yeah. So 60, as it's indicated with AHA,
Right.
which our protocol will also say here in the near future.
We have no explanation for why it morphed to that.
All right. Anybody else have any questions, thoughts, personal experiences with neonate or with additional hands-on scene?
No, you definitely do intubate as needed, but remember that, as in most of what we do, the foundation for good care is good BLS, and particularly in infants and neonates, starting with good bag valve masking is the key.
Thank you. With no other comments, we'll move on to case 3 of a 38-year-old. This was a case where EMS was contacted for, I believe that the dispatch information was near syncope. The patient was found to be awake. His airway was open. He was protecting it. He was pink, warm, dry. There was no signs of bleeding. Vital signs were obtained immediately upon arrival with the patient. Heart rate 77, blood pressure 137/96, respiratory rate of 18, and SATs of 99%. This is a young patient, for all intents and purposes, 38 years old. So he had reported no past medical history, no medications. And the history that he did provide was that 30 minutes prior, he had completed a cycling workout. Following it, he developed near syncope, dizziness, and weakness. His wife reported that he became unresponsive, in the fact that he was just kind of a blank stare, and that she helped him to bed. And he states that he just doesn't feel quite right and describes it as being uneasy. Vital signs I already reported to you. 12 lead was obtained perfectly within a few minutes of patient contact. The 12 lead, when I look at it, I think this is not a normal looking 12 lead for a 30-something-year-old. When I look at this, I say, so, obviously it looks regular. So, you're kind of saying this is sinus rhythm based off of these P waves. But the things that I look at when I look at this is that, does this patient have LVH? Why are these T waves so peaked? And then you kind of look at the QRS and you're like, no, they don't even have widening of the QRS. And then you start looking at these segments here and you got this ST, depression. And you're like, well, maybe it's just in 1 or 2 leads of the inferior leads, but it's in all the leads. So then you're kind of like, all right. And then you're looking at, for me, so I'm looking at this EKG, it looks abnormal. I see ST depression in the inferior leads. These look like they could be, related to hypertrophy, but they have, they're concerning for ST elevation. And then you have this T wave inversion, which could be representative of myocardial ischemia. And then you have these really peaked looking T waves. And if you follow Steve Smith's EKG blog, any T waves that are the same size or bigger than your QRSs should alert you to concern for myocardial injury. You start kind of thinking, ooh, this doesn't look normal, especially in context of a patient who had these kind of cardiac symptoms after exertion, and you don't have an old 12 lead to look at to compare. So that's my take on it. Does anybody else on this call have any take on this 12 lead?
No, totally agree.
So another set of vital signs were obtained, largely unchanged. A blood glucose was checked as well. The documentation is that the patient was discussed with treatment and transport options, and that the patient, Boise, didn't want to be transported, and that the EMS crew documented that the safest route is to be transported and evaluated by an MD, and that the patient still didn't want to be transported, and that the EMS crew documented that POV is acceptable and to follow up with a PCP if possible. So kind of was, at least in the documentation, it went from, hey, this sounds like the criteria for an AMA refusal, but then we also document that an AMA refusal is indicative that we think transport by us and immediate evaluation at the hospital are necessary, but then we're saying PUV is acceptable, and maybe if your PCP is available, that's not going to happen likely in the same day, so a couple days. So it's a little bit conflicting on the concern here. The patient wasn't transported, there was no Pulsera. And then I will point out that this was 6:53, so almost 7 p.m. That comes up later, so. In reviewing this case for this presentation, I thought that early and serial vital signs was great. 12 lead within the first 3 minutes. You know, our state KPI is less than 10, so met it by a large margin of grace. And then that areas for improvement. This is a patient that should be transported and evaluated at the emergency room in the same hour, ideally. So this would be an AMA refusal. So base contact is mandatory. So no base contact was initiated for this patient. Anything else to add from those on the call?
I would have just run that in as a STEMI.
Yeah, I mean, definitely a red cardiac. It may, if they put it in the STEMI, you may or may not have had the doc at the hospital agree, but definitely concerning for sure.
But then they
Yeah,
get the
I don't
evaluation.
know.
right there.
And what's that?
Go ahead, Dr. Weber.
No, yeah, if you call it a STEMI, then you get the physician to look at it. And then you get the physician and then if he or she says, no, it's not a STEMI, you're going to evaluate the patient when they hit the door anyway. So, so there's no delay. And then if the patient says, okay, if you say, I think you're having a STEMI, I think you're having a cardiac event. He says, no, I'm not going to go to the hospital. Then that patient needs to hear from the doc right then and there.
Absolutely. And one of the things that Dr. Whitwer just brings up that reminds me to mention here is that if you guys put it in as a STEMI for Peace Health, and I assume that'll be the same for Legacy Salmon Creek when they start going operational, that it automatically turns it into a red receival of EMS arrival. You don't have to change it. So if we get it as a STEMI from you guys, we consider it a red even if we downgrade it. And Dr. Mock, were you going to say something?
No, I think putting the CKG in front of a doc is the right thing to do.
Yeah. So EMS made contact with this patient around 7 p.m. Around midnight 30, the patient presented to the emergency room, presumably with similar complaints. EKG shows smaller lateral ST depression and septal infarct. So this is the hospital EKG where the documentation is lateral ST depression. So I think over here in your precordial laterals that you were probably seeing that ST depression and then continued T wave inversion in question 2, septal ST elevation. But I brought up the old one or the original one, and you can see that I think that it was much more prevalent in the pre-hospital EKG than in the hospital.
Mhm.
And this is for, 3.5 hours later.
I think what's interesting about this one, which is kind of an interesting thing to note, is that if you look at, can you bring that back up, the original one? And it's this, so you've got this little bit of elevation in V1, but then with a significant inversion, where then you go to V2 and you have a lot of ST segment elevation. So these are contiguous leads. Curiously, some people will get, with a septal infarct, they will also show elevation of the ST segment in AVL. And this one has it.
Mhm.
So this is a pure septal infarct.
And you can say too, when you're looking back, hindsight's always 20/20. I recognize
Yeah.
that, but you're looking at what looks like potentially ST elevation in AVL, and you're like, well, is it? But then if you go back
Yeah.
to the, hey, this T wave is as high, if not taller than the QRS, that's concerning. So even though you don't necessarily want to pull a trigger for ST elevation in lead 1, you've got changes that concern you for cardiac injury and what
Right.
looks like ST elevation here.
You've got a septal lateral thing going on.
So
And I agree
go
with
ahead.
all the comments about the EKG, but I guess my perspective on this is exertional syncope, abnormal EKG,
Yep.
AMA.
Yep.
Wait, what was the last thing? Exertional syncope, and then
Exertional syncope, abnormal EKG, AMA. Like, means we need to use all the resources at our disposal to get this person to the hospital.
yeah, like AMA is like your last option. Definitely you want this patient to go to the hospital.
Yep.
So initial troponin was elevated you guys use high sensitivity troponins at Legacy,
No,
Dr. Mott?
no. So abnormal in this on this lab test would be greater than 0. So the gray area would be 0.03 to 0.5. Anything above 0.5 is a positive troponin.
And the only reason I mention that for anyone who is looking to expand their knowledge outside is that it's all about the scale. So at Peace Health, we use high sensitive troponin. So our scale is 0.04 or less. And so it kind of gives you an idea of how the scale is different, and it's all about the scale you're using. So yes, this is abnormal. The patient's pain was controlled with nitroglycerin. He went to the cath lab the following morning. He underwent PCI, percutaneous cardiac intervention, to the LAD with aspiration thrombectomy, and was discharged the following day. As far as I know, and Dr. Mock, you can update me, he did not get a stent, just the thrombectomy, correct?
Correct.
Okay. I asked. Okay, I asked Mark to
Right.
look it up for us, so thank you. So a brief conversation about syncope. It's a transient loss of consciousness or tone with spontaneous resolution. Up to 3.5% of all ED visits annually are because of syncope complaints. The etiology falls into one of these 4 categories. The ones that we want to be most concerned about are going to be your cardiovascular and your cerebrovascular. So your cardiovascular are going to be like arrhythmias, either slow, like heart blocks, or tachydysrhythmias, like VTach. Structural problems such as like aortic stenosis, or if there's hypertrophic obstructive cardiomyopathy, or if there's other obstructive causes such as a pulmonary embolism or an MI. Cerebrovascular incidences are going to be impediment of the blood flow to the basilar artery system. And then blood flow and tone, usually that's under the vasovagal, orthostatic, or situational, like coughing or extreme pain. And then other things that might mimic a syncope are seizures. Some people say you can tell a difference based off of incontinence or oral trauma. I think that you have to consider the whole entire history preceding the patient's history and have some good data that you can't necessarily just say, oh, this happened, therefore it is a seizure. Metabolic causes like hypoglycemia, and then psychogenic like panic attack along those lines. Some patients will have a prodrome where they'll be lightheaded. They might have cold symptoms, like they feel cold, vision changes, they might be nauseated. And some patients might not have any prodrome preceding the incident. That tends to be more the case with elderly patients. And the history is going to be really helpful because a lot of times we cannot identify why a person had a syncopal episode. So the history prior to their syncope is helpful to try to elucidate what are the etiologies, as well as how long that they were unconscious for, and if they have any symptoms following the syncopal episode. That's why it's really important to do a really good cardiac neurological exam and get a good set of vital signs, a full set of vital signs. Evaluation of these patients in the hospital, well, evaluation in the pre-hospital setting would be getting glucose and getting an EKG. An EKG will come up with 5% of the causes of all the syncopal episodes. When labs are obtained, like a full set of labs, that might come up with a reason for the patient having a syncopal episode up to 2% of the time. Other things that are going to potentially be performed on these patients, depending on context, is going to be an echo, sending them home with a Holter monitor. They might get imaging of their head, either in the form of MRI or CT, based off of if there's concern for a cerebrovascular event. They may get an EEG if they think that there was another mimic or a tilt table, but nonetheless, these all explain things that don't happen in the pre-hospital setting. So these patients that have syncope should be transported, especially if we're worried about cardiovascular or cerebrovascular etiologies. It did say that up to 50% of syncopal episodes are related to blood flow and tone, but we don't want to miss the ones that are the first two. So in our protocols, most of this is what I just presented. And I would say that, they mentioned for cerebrovascular, you might want to go down the stroke protocol. If the patient's still altered, go down the altered mental status protocol and treat the patient under the universal patient protocol. You're going to be managing or evaluating for any dysrhythmias, MIs, hemorrhage, or shock. And I think that the only thing that I would maybe suggest that you do is check a blood glucose in the event that hypoglycemia led to syncope, as that is one of the causes of syncope or potential causes of syncope. All patients suffering from syncope deserve hospital level evaluation, even if they appear normal with few complaints on scene, which that, like we all have mentioned, this is a patient in this context that has a very concerning EKG and a history preceding. So reiterating the importance of this patient being transported. And then high risk causes are listed here, which you can see are the cardiovascular causes that I mentioned, and the cerebrovascular event, such as a hemorrhage or stroke. Also thought it'd be a good moment to reiterate the refusal of care. Because of time, since we're already at 10:12, I'm going to skip forward to patients that need immediate medical care or ambulance transport. Refusal form is necessary. Every effort should be made to convince these patients to be transported and evaluated. And you can elicit the people that are in their life. I think that really appealing to what they consider important is really helpful in trying to convince a patient, especially when you're like, why are you refusing? And you ask them, why are you, or what's your hesitation to go to the hospital? And they might say, I got to pick up my kids, or I got to take care of my pet, or I have like this appointment, tomorrow or later on today, and you can help address their concerns so that they can feel freed up to be able to take care of themselves. And then you may want to solicit law enforcement for help, but consult with medical control is mandatory, and anybody that we consider immediate medical care or ambulance transport is necessary. The reason why we're calling medical control is to see if they might be able to persuade the patient to go, since sometimes just the title itself or the demonstration of concern from the paramedic is enough to convince a patient otherwise. Anybody else want to add anything to AMA refusals
Yeah,
and
just-
syncope?
I think the key thing about AMA refusals is, one, if we don't, when I look at this as a system, making base contact on AMA refusals, this is not something that we do very well on. The percentages are very low. And I think it's an area where we can really improve our patient safety. That there are two parts of that. So if the patient is not AMA, you don't need to call it AMA. If they have a scrape on their leg, you bandage them, that's not AMA. Whereas you think they should go to the hospital, they don't want to go to the hospital. We wanted you to involve the physician. As Dr. Gadbois said, the title alone can be helpful, but then the additional explanation of risks can be helpful. When it's been studied, it's between 25 and 45% of the patients that don't want to go. You get a doc on the line, you can convince them to go. So it's an important EMS intervention for the patients that are truly AMA.
Absolutely. All right, so our last case is of an 18-year-old male complaining of shoulder or scapula pain. He was found to be alert. His airway was open. He was protecting. He was also known to be pale, cool, and diaphoretic, but no signs of bleeding. Vital signs were obtained a minute after patient contact with a normal heart rate of 70, blood pressure of 118/94, respiratory rate of 18, and SpO2 of 100. The only past medical history that this patient shares with EMS is that he's a smoker, presumably of nicotine. I don't know if it was anything else. Medications were none, and the history preceding the patient's initiation of his complaint was that he was eating dinner and he was about ready to get up and all of a sudden developed left shoulder and left scapula pain. When he did get up, he had a syncopal episode for 1 minute. There was no reports of seizure-like activity, and he was breathing irregular, according to his family members. Vital signs, as I had previously reported, the patient had an IV established, and his blood glucose was checked 3 minutes after contact. And the patient described, this is actually probably one of the best narratives in regards to the patient's complaints, a description of his symptoms, as they went on to describe it as dull aching that was constant, worse when he took a deep breath, and rated his pain as a 7 out of 10. And they placed him on nasal cannula oxygen at 4 liters, and they got another set of vital signs largely unchanged. They got a 12 lead right at the 10-minute mark. So meets the criteria, but probably room for being able to get that on sooner. EKG shows regular rhythm. I would say kind of low amplitude in regards to lead 1, but looks like physiologic left axis. No, sinus left or normal rhythm or normal axis. Sorry. He's got these really elevated R waves and what looks like maybe some ST elevation, but in the context of this patient, it probably isn't ST elevation, although, we talk about zebras sometimes in these case reviews, but this is probably more likely early repole, and especially because it's concave instead of convex. And yeah, I would say that's my interpretation. You can see that, you might say this is ST elevation, but based off of the shape of the ST segment, this looks more like early repolarization for me. I was going to say early R wave progression, but that's all. Transport was initiated 11 minutes after patient contact, and he was given 25 micrograms of fentanyl twice during transport. Vital signs were repeated, including end tidal, no issues documented. There was no Pulsera because at the time we weren't using Pulsera at Legacy Salmon Creek. And the QA discussion, I thought that the documentation was really good in regards to the patient's preceding history or preceding events prior to the onset of his symptoms, as well as the description of his pain. They did early, serial, and complete vital signs, so not partial. And then they did get a 12 lead within the 10-minute mark. They got IV access, they controlled his pain, but controlled his pain in a reasonable amount as opposed to going 50 or 75 or 100 mics with each interval. They gave just a small amount of 25 mics each time. Areas for breath sound assessment. They, if I remember correctly, they did not document breath sounds. So really a small area for improvement. And in the emergency room, he was seen in triage. He had labs done, a chest x-ray, and the chest x-ray showed a small apical, so very top left pneumothorax. Given small size, they admitted him for observation. They got a repeat chest x-ray that showed interval enlargement of his pneumothorax, so they placed a chest tube. He was discharged on hospital day 5 in good condition with the chest tube removed. So this is not the patient's chest x-ray. This is just for demonstration here, but since it's the first thing here, you've got normal lung markings on the left side. This represents the right side. You've got this kind of darkening area. This represents no lung markings because the lung markings are down here, so represents a large pneumothorax on the right. So we're going to talk a little bit about spontaneous pneumothoraxes. These are pneumothorax in general is an abnormal collection of gas in the pleural space between the lung and the chest cavity. Spontaneous ones are when they occur without obvious causes. So no trauma, no inciting event. And they're classified as primary or secondary. Primary is without underlying pulmonary disease, and secondary are with underlying pulmonary disease such as COPD, asthma, malignancy, stuff like that. This typically is more commonly occurs in adults than pediatrics and more commonly in males than females. Other risk factors for developing a spontaneous pneumothorax is a smoker. This patient was a smoker, or tall or thin body structure. I don't know if this patient was tall or thin. Interestingly, this most commonly occurs at rest. And then the diagnostics that can be used is an X-ray and ultrasound, but a CT gives us a better idea, the extent, especially if we're talking about a large one, but X-ray does a pretty good job for large ones too. And then the treatment is, and actually I meant to put that into the kudos for the good on the QA discussion, is that giving these patients oxygen, the highest form without, providing positive pressure, is actually beneficial. It can help absorb the air in between the pleural space up to 3 times as fast than without oxygen. So a good call on this crew's decision making, even since the SpO2 is documented as normal. And then, so some patients just get supplemental oxygen in observation, and if the pneumothorax increases in size, especially if it's a rapid increase in size or concern for attention, needle decompression and chest tube. So at this point, we would be looking at our protocol for chest pain, because patient at back pain, shoulder pain could represent chest pain. Also could all fall under the syncope protocol, but I just presented that to you guys, so we're going to talk about acute chest pain. So supply oxygen if needed, to maintain sats between 94 and 98%. So could say that it wasn't indicated, but given that this patient had a pneumothorax, oxygen was a good call. Get a 12 lead, potentially treat with aspirin unless there's a contraindication such as allergy, ulcer, liver failure, or severe systemic disease. If the systolic blood pressure is greater than 110, you can consider nitroglycerin. I think that this crew did an appropriate decision making in saying that, this could be chest pain. This definitely was syncope, but we're going to hold off and treat pain with the fentanyl in this case, more so than going down the aspirin and nitro at this point. Any other thoughts or comments? All right. Well, we come to the conclusion about everything that we've talked about. So with the first case, we talked about pulse form, having it filled out properly. The first section is the DNR discussion, and then the second section is the level of medical interventions that we talked about, that it needs to have the patient's name, it needs to have the date, it needs to have the healthcare agent, and then the medical provider signature and date as well. So you can kind of see this section down here. And then second is that AMA refusals. These are patients that we think that need to be evaluated immediately and preferably by ambulance. They've signed paperwork if we can't convince them to go, but part of that convincing them to go should include online medical control. Neonatal resuscitation is going to be really focused at managing the respirations and ensuring an adequate airway. Warming the patient, potentially dealing with warming issues, and then if the heart rate is below 60, potentially initiating epi or CPR as needed, and consider blood glucose down the road if you've managed ABCs. And then spontaneous pneumothoraxes, they tend to occur in males and adults. They can occur at rest, and they can occur with underlying pulmonary disease or no underlying pulmonary disease. And that if your suspicion for pneumothorax is high or is on your top 5 or 3, I think giving them supplemental oxygen regardless of their SpO2 is reasonable. That is all I have. Anybody else have anything to add? Did I lose you guys?
No, thank you very much for doing that.
Yeah. All right. Well, thank you guys for your time and attention. As always, if you have any questions or you want to, want me to review any of these cases for upcoming case reviews, feel free to send me a message either by email or text. And thanks for your time and attention and dealing with the difficult things out there and learning from each other here.
Thank you, Dr. Gabois.
Yeah.